Alhamdulillah, salatu salam ala Rasulullah. Now we are in this session starting the beginning of treatment of mycetoma. We have got, I'm chairing this session together with Mr. Suleiman Hussein. We have 4 speakers. We will introduce them alternately, Mr. Suleiman, myself. And our first speaker is Dr. Hail Al-Abdali. He's an associate professor in Al-Faisal University. He is a consultant infectious diseases in King Faisal Specialist Hospital in Riyadh. His main interest, and I'm pleased to say that his main interest in infectious disease is mycology. We don't have many of those kinds. He has a good experience which he is going to tell us. Dr. Hail Al-Abdali, tfaddal.
Thank you, Professor Mahjoub. And Assalamu alaikum. Good morning, ladies and gentlemen. I'm happy, honored, and proud to be here in Sudan for the first time. And I would like to thank the organizing committee and everybody for the hospitality, generosity, and kindness that I and my colleagues has received here. I work primarily as an infectious disease consultant at this institution that you see. This is an aerial view of King Faisal Specialist Hospital, which is the main referral center in the Kingdom of Saudi Arabia. This is where we get the complicated cases referred to us from different hospitals in the kingdom. And what I'm going to discuss now is medical therapeutics for mycetoma, and mainly fungal mycetoma. I think we have seen many pictures yesterday, and especially yesterday, with amputations and mutilating lesions. And once we see a patient with amputation, this is a failure of medical therapy. By then that we have reached this stage, then we have failed in treating such patients. And this is for good reasons that I'm going to discuss. Dr. McGinnis from Galveston, Texas, has made a review in '96 where he tried to lump all the cases of fungal mycetoma to find out which ones are the common. And Madurella mycetomatis was the most commonly reported, and I think probably is the most common, even unreported. Then Scedosporium epiospermum has been the second, and this is a fungus where you see in tropical and also non-tropical. So if you have a mycetoma somewhere in Europe or in other regions, this is likely to be Scedosporium epiospermum, or the old name Pseudolicheria boydii. Then we have some others that we've heard about yesterday, like Leptosphaera, Madurella, others like Grisea and Acremonium species. This is a map I basically adapted from the paper by Dr. Abdullah Uthman and Professor Fahal. And I've added, just modified it a little bit to add some of the case reports of the distribution of organisms. And you can see around the mycetoma belt, you can see Madurella mycetomatis in red, basically all over. And then you have some Grisea mainly in South America and in India, but also it is in Africa. And then you have some other species. Success in therapy started always with understanding of the process or what's going on. And you can see with this schematic presentation or graph of mycetoma, you can just from the look say, well, this is difficult to treat. This is forming roots, forming channels, forming grape-like areas with a thick capsule. Then this is really likely to be, from anatomic standpoint, difficult to treat. If we catch the patient early on with just a few of these, maybe we can treat him or cure him even without medical therapy, just cut and get out. Or if we treat with medical therapy, we are likely to be more successful because the bulk of the organism is less. And this is one of my patients who more or less will have that schematic graph if we would have it. It's a very destructive Eumycetoma, and everybody was telling him he would need amputation, so he escaped basically. I haven't seen him afterwards. And this is, I think you have seen it yesterday from Professor Hassan, the vesicular type of hyphae on the sides and the grains in the center. And this is the capsule where we believe maybe it's hindering the effect of our drugs against mycetoma. And sometimes, as indicated also in some of the discussions, that if we give antifungals, maybe this capsule will be limiting the disease and maybe we can cut it off easier. So how to treat fungal mycetoma? I think we have to have a strategy rather than, you know, jumping in a fast fashion. We have to think about the patient. In general, in infections, infection happens because of imbalance. Imbalance between exposure to the pathogen, and that is dictated by how much we get of the organism, inoculum size, and also virulence of the organism. On the other hand, it is also related to the host defense of the host. And again, we know still nowadays, we know very little about all the host defenses in the system, and we don't know why some people get fulminant pneumococcal pneumonia, for example, while others, they get low-borne pneumonia. Or somebody get very bad encephalitis with herpes, and some, they had just the cold sore. So mycetoma is within the scope of this knowledge, that we don't know all of the host defenses. I think the work that has been presented by Wendy yesterday was excellent and was, as she said, I mean, a start point to understanding more the susceptibility of host to fungal organisms causing mycetoma. And exposure and inoculum is important because it has been shown in experiments, especially experiment animals. If you give large dose of organism, fungi and others, you can induce infection even in the most resistant model. And this is, I guess, is also applicable to humans in many instances. Okay, so part of the strategy is to look at the patient and see what will determine a better outcome for your patient. I think, as has been mentioned several times in this conference, early diagnosis is pivotal. If you find a small lesion, then you are likely to be very successful versus a very large and deep lesion reaching to the bone. And that, of course, require a self-conscious about this by educating the community, so they know that this is likely to be maybe a serious condition and they have to seek medical attention. Extensive tissue involvement, I've already mentioned that, and as it gets more, it gets difficult. And as it reaches the bone, it's really become very, very difficult. This is for fungal mycetoma, and you know, fungal mycetoma compared to actinomycetoma is really very bad news to the patient. Surgical causative organisms is very important. I have cases in which refer to me as fungal mycetoma. Patient never had a biopsy, never had a culture, nothing, and was placed on cotrimoxazole and itraconazole, so covering both possibilities. And this doesn't work really. We have to determine the causative organism to the species level, and even the strain, because even Madurella and, you know, strains, they differ in susceptibility to antifungals. So it's very critical that we know the organism as well as even the species and even the strain, and if we can, maybe do some susceptibility testing. As I have just mentioned, surgical treatment can be curative. If you have a small lesion, you can just cut it off. Selection of antifungals is critical, and this is the main focus of my talk. And I'll be focusing on Madurella mycetomatis in particular. But it's not, you select what you have. I mean, if these drugs are not available, not affordable, then probably it's irrelevant. So they are there somewhere, but you cannot use them. So this is a main obstacle that is facing patients with mycetoma, because these are in typically lower income areas where they cannot afford the drugs, even if these are effective drugs. Duration of therapy is kind of arbitrary, and it has to be individualized. But you have to have upfront vision towards probably how long this patient is going to need therapy. Immune status, genetics, I think the work again presented by Wendy is quite interesting, and maybe we'll know more in the future. Okay, so the focus of my talk is about antifungal, and this is my main work, is dealing with antimicrobials. So as I said, identification of the causative organism is critical. If you have in vitro data, it's helpful, but you have to be cautious. In vitro data does not translate always into in vivo data or in human effect. So it's a clue, it's helpful, but it doesn't tell you the whole story. Animal data is very useful. It has been very useful in invasive fungal infections, candidiasis, cryptococcosis, cocci, aspergillosis, and we have some models that has been published in the literature, but not on therapy. They're just induction of the disease. And as we have heard yesterday, there are natural infections in animals that has been noticed. So I think these can be useful to try therapy. But again, this needs really a good commitment, because this is not a 1 week, 2 weeks, 1 month therapy. This is probably a prolonged therapy that really needs dedication. Clinical data, again, all of the antifungals we have hasn't been developed for Madurella or fungi of mycetoma. These were developed for other fungi, but we've used them, and some of them seems to have an effect. So we have a few clinical data, and these actually preceded the in vitro studies. Okay, what do we have nowadays? I mean, in the market, we have many antifungals. We have the polyenes, and we have amphotericin is the oldest, and it is called amphoterable because of the toxicity, especially renal and others. But now we have more safer drugs, but very expensive drugs, liposomal amphotericin B or amphotericin lipid complex. Safer, but very expensive. So this is really a trade-off here. The azoles has been our favorite drugs, and they've been good drugs for us for many reasons. These are oral agents, and some of them can be used also IV. They're pretty safe and can be used over a prolonged period of time with a pretty good safety profile and good pharmacokinetics. We have the imidazole. This is wrong triazole, because this is an imidazole. It's not a triazole. But we have fluconazole. We have itraconazole, voriconazole, posaconazole. These are a pretty useful drug to us. Then more recently, we have the echinocandins. These are the penicillins of fungi. They work on the cell wall on the beta on the beta glucan, and they seem to be quite effective in yeast infection. In mold infection, maybe aspergillosis, but so far they haven't been very well studied in mold infections. The few anecdotes suggest probably they're not as good. Some fungi, they don't have beta-glucan. They make alpha-glucan, like zygomycetes, cryptococcus. So, and I don't know about Madurella, probably also alpha-glucan. And these drugs, they don't work. These are parenteral drugs. And you know of the difficulty of treating a chronic infection with a parenteral agent. We have terbinafine, which is a typical dermatophyte type of drug. It's oral, it's safe, and has been useful in some cases. I'm going to show you some. Graceovolvin, also the old drug from the 50s, really modest effect. We have 5-FC, which is a derivative of mercaptopurine. It's a bit toxic and if used in high doses, and hasn't been very useful for us. So if we have to define the areas or the errors in which we were dealing with medical therapy of Eumycetoma, we have the pre-azole era in which Ampho was the only drug and doesn't work, toxic. So then surgery was the only option. And then a lot of amputations were done then. Then we have the imidazole era, which is a little bit better. Then we have the Triazole, which has been kind of a breakthrough in our management. And now we have the Triazoles, the second generation Triazoles, and they seem to have better kinetics, more potency. So they seem to be better drugs for us. And then we have some of the non-azole therapeutics. So the pre-azole era, mostly surgical, Ampho really bad. Graceovolvin, some anecdotes. I don't know if it was even working. They said modest effect, but not much. 5-FC we cannot use. Dapsone has been used, and probably through its immunomodulating properties, it has some effect on mycetoma. But all of these are not very good in terms of treating Eumycetoma. Then we move to the imidazole era, in which we have the Fluconazole. We have it IV and topical. No longer we have it nowadays. It was replaced by better drugs. And there has been some cases of invasive pseudolischuria treated successfully and get famous actually for that, more reality. And then we have the topical clotrimazole, and we have a lot of topical azoles. And some people have tried to apply it, really no effect, and it's not useful. Echinocandins has been a breakthrough in antifungal therapy. It's the first oral agent that is relatively safe and effective against many yeast, dermatophytes, and even molds. Okay, moving to the Triazole era, Fluconazole, which was introduced in 1990, has been a breakthrough in treatment of invasive fungal infection, especially Candida, but also works very well against many yeast-like organisms, dimorphic fungi, cryptococcosis, etc. It's probably the best drug in terms of pharmacokinetics, bioavailability, IV-like oral. We had a patient with short bowel syndrome, only 20 centimeters, and we've given oral Fluconazole, and we've measured the levels, and it was equivalent to IV. So it's a very good drug, but again, problems with Fluconazole, limited spectrum for filamentous fungi, including Madurella, in terms of clinical efficacy. In vitro, I'm going to show you some data, but in clinical efficacy hasn't been very good. Itraconazole, this is a drug with a long history, started in '92 with a capsule. The capsule is problematic. It does not dissolve very well. If you are using antacids or acid suppressant, H2 blockers or PPIs, then it's not going to be absorbed. There's a dose-to-dose variability, patient-to-patient variability. So it has been a problem with the capsule. Then in the late 90s, they made it in solution, taking care of this problem of absorption. And it was good, but I have it and I've used it. And it caused really significant diarrhea in those patients. And whenever they have diarrhea, they relapse, those patients. So I always caution them, if you have diarrhea, come back, because this is not likely to work. Then the IV solution, also we have used this as kind of induction therapy the first few weeks, and then consolidate with oral therapy. It has a negative inotropic effect on the heart, so you have to watch if a patient has heart failure. But this is the most common drug used for Madurella. Voriconazole, this is the newer. It has a better kinetics. Bioavailability is very good. It works against some resistant organisms, including Fusarium and Scudosporium epiospermum. And this drug has been really a very good drug for aspergillosis. Nowadays, it's the drug of choice for all forms of aspergillosis. And I think it's a drug of potential role in mycetoma. But I'll tell you about the price at the end of my presentation, because that's a big, big obstacle here. The most recent is Fluconazole. This is a drug I worked with in the lab, and then in animals, and then in humans. And it's a very good drug in terms of potency, but and very broad spectrum. It works against the mucorales, causing mucormycosis where we don't have except amphotericin B. The problem with it, they could not make it into tablets or capsules because it doesn't get absorbed. So they made it in solution, and then that solution, the absorption is not always predictable, and that you have to get it with a lot of food to get absorbed. It's approved for prophylaxis in bone marrow transplant and leukemia. But we have used it in few cases of phaeohyphomycosis, and I'll show you also a case I have used it in. And it seems to be a pretty good drug. The company is working on making an IV formulation of this drug. Then we have some in the pipeline. We have Fluconazole, which is in phase 3 now, trials for aspergillosis, albuconazole, which initially was developed in Argentina, and now it's in, I think, phase 2. Ravuconazole was earlier, but it has problems with toxicity. First pass in the liver was also extensive, so I don't think ravuconazole will be a drug we will see, but Isavo maybe, and it is in IV and oral formulation. Other antifungals, we have the Echinocandins. I have just shown you the 3, the caspofungin, micafungin, and idurofungin. We have caspo in our hospital. And as I said, it doesn't seem to work very well for molds in general. Terbinafine, I'll show you some data on terbinafine. So in vitro data, until recently, we haven't had really good in vitro data. But thanks to the collaboration between Khartoum and Rotterdam and the work of people like Wendy, Abdullah Uthman, they really have done nice studies on the in vitro susceptibility of Madurella mycetomatis, and I'll show you some of their work. This is in vitro susceptibility of Madurella mycetomatis, and again I would caution you about the in vitro correlation with in vivo. These are good clues. They may just give us a start point that we may use these drugs, but it does not translate into clinical efficacy always. And there are no breakpoints for any filamentous fungus, including Aspergillus. The only breakpoints we have is mainly for azoles for Candida. This is the one agreed upon. Otherwise, we don't have any breakpoints. So it's just a clue, but we have to be cautious looking at it. So this is 34 strains of Madurella mycetomatis treated in, tested in 3 methods. The typical NCCLS, or now they call it CLSI method, which is a visual look at growth, or sensititer, which is a colorimetric, and we use that for yeast in our lab, or the XTT, which is a viability test. And if you look here at Fluconazole, these are 34 strains, and look at the minimum inhibitory concentration, we can see that a good number of these isolates are probably below the 16. If we take the Candida breakpoint for Fluconazole, then 8 is susceptible. 8 and less is susceptible. 16 and 32 is dose dependent. You increase the dose, you get efficacy. 64 is resistant. I don't think we can say that here because this is not Candida. And we know that Fluconazole, although in vitro here there is some activity, really it didn't work in humans, in patients. So I don't think Fluconazole is a good drug to treat Madurella. Okay, moving into Itraconazole and Ampho. Again, this is Dr. Uthman work in Rotterdam. And you can see here Itraconazole in yellow has MICs down to 0.5, which is probably the limit in Candida, for example. If we have to have the analogy of Candida, then in Candida 0.5 is where we stop, and then after 0.5 we say, well, it's resistant. So it shows good activity in vitro against Madurella. Amphotericin B, we don't have breakpoints even for yeast, but around 1 we say, well, above 1 probably resistant. So Ampho seems to have in vitro activity. It hasn't been really tested well in patients because of the toxicities, difficulty, and now with the liposomal, the cost. Moving to voriconazole. I mean, this is a new drug. It seems fabulous in many instances. And again, measuring it with the 3 methodologies, it seems to have a very good in vitro activity. You can see the MICs here down to almost all less or equal to 0.5. So it seems to be a very good drug in vitro with all of the cautions I have already mentioned about in vitro testing. This is a paper which was published only yesterday, I guess, and I would thank Professor Fahal for providing me with the paper, testing now Fluconazole, which is our newest Triazole. Here we have Fluconazole, terbinafine, Itraconazole, and Ketoconazole. These are the drugs typically supposed maybe to work against Madurella. And you can see Etraketo, keto in blue, Etra in yellow, and Posa in red. They have a very good MICs, quite low. Terbinafine is higher, but again, if we look at the pharmacokinetics of terbinafine, you can reach serum levels up to 4, maybe 8. So still it's a useful drug maybe if you give good doses. So even terbinafine may be useful for Madurella. How about the Echinocandins? Well, you can see here 3 Echinocandins, yellow, red, and green. That's caspofungin and idilofungin and mycofungin, tested against 17 strains compared to ketoconazole, and you can see it's pretty resistant. I mean, doesn't work. You have most of them on 16 and above, and mostly more than 128. So Echinocandins, they don't work. Anyway, they are parenteral. We cannot use them oral. So I don't think they will be useful to us. Could we use them as combination? They have been tried in some resistant cases like mucormycosis. Anecdotes say maybe they are better than one.